Basic concepts of treatment planning partial edentulous patients with implants. So today we will talk about the concept related to a single implant restorations. This is the common pictures we saw, that the before-after pictures. However, we do know that the real treatments actually involve multiple steps, included the treatment planning, wax up, the surgery, final impression, and the final restorations. So today we will discuss this by sequence. So the treatment sequence of the single implant restorations included several steps. One is about data collection. The second is diagnosis and do a treatment planning. The third part will be the surgery and prosthesis. In each different field also included the different treatments. So in data collections, it was included by the cast impression, do the x-ray, do a diagnosis, and to get the history. In the diagnosis and the treatment planning, it may include the wax up, how to design the implant restorations, and where to place the implants. Finally, to do a surgery and the prosthesis were included the surgery, the final impression, the final prosthesis, and even the follow-up. So in the diagnosis and the treatment planning were included by those three different fields. We included the wax up to determine where to place the implants and how do we design the implant restorations. For the diagnostic wax up, it will be able to tell us several important information like the position of the implants and the crown, how to distribute the crown and the implant in the edentulous area. Also, this diagnostic wax up also will be a good communication tools between the clinicians and the technicians. We also can use those diagnostic wax up to do a radiographic or the surgical stand to get a better diagnosis and treatment planning. The principle of single implant restoration designs actually will involve to multiple factors like the number of implants, the length and diameter of the implants, how to align and locate the implants, also included the implant restoration design and material selections. Those different factors are important and will be discussed in the following slides. So first, the number of the implants was needed actually mainly depending on the number of the teeth will be replaced. So basically, we'll talk about ideally we want one implant to replace one missing tooth area. However, this also will relate to the mesodistal length of the dental space, because we do know when patient lost the tooth for a long time, the remaining teeth might migrate to the edentulous area, which will cause the space will be less than ideal. So how many teeth really able to accommodate it into the missing tooth area to get the full functions and aesthetic is very important. The third part is about aesthetic requirement. So the spacing of the tooth, how to contour the soft tissue, also will relate it to how many implants you are going to place. So do we really need one implant for single missing tooth? This paragraph actually is from a research in 2007. The researchers collect a lot of different papers and comes up the survival rate for the statistic result. In their research, they really shows that, as you can see, the green one is the implant bridge, the blue one is the implant single crown. So in 5 years, actually they both have higher than 90% to 95% survival rate. In the 10 years, they still have over 85 to 90% survival rate. Even though you can see the green one, the implant fixed bridge, is slightly lower than the implant single crown. However, in the statistic, they are not have a significant difference. So it means that if you can place an implant for a single restoration or for the implant bridge, the both options can work. The other factors will also determine the number of implant was needed. First is about the location in the arch. Remember in the previous lectures, we discussed about the difference between the natural tooth and the implants. So we do know that the implant doesn't have a PDL around the bone. The implant has a direct osteointegrations with the bone. So the force distribution is a highly determine the successful rate of the implant restorations. So as we know, the posterior teeth actually get more force distribution than the anterior teeth. So if we plan the posterior implant restorations, then we were more likely to have one implant for each missing tooth. Also, this is related to because the molar is wider than the premolar and the canine and anterior teeth. So it would be better that to have one single implant to replace one missing tooth will get a better force distribution and higher success rate. The second will be about the type of opposing dentition. So if the opposing dentition is a natural dentition, that means that the force distribution will be higher than when the implant was opposing by the dentures. So if in the natural dentitions, ideally it still be replace the single implant restorations for all the missing area. The third one will be the power functions. So if patient have power functions and you still want to do an implant restoration, the first is try to eliminate the power functions. The second is to place enough implant to distribute the force to enough implant bodies. When we talk about the length or diameter of the implants, actually they were related to those 5 different factors, which will be discussed in the following slides. When we talk about the length and diameter of the implants, the first is to know the crown implant ratios. The ideal is at least 1:1 by the crown implant ratios, just like a natural tooth to the root. So ideally that we want to place the longer implants to get a better crown implant ratios. So the longer implant is favorable, but has some limitations. Because if we want to place a longer implant means that we have to drill a hole more deeper. As you can image, when you drill a very deep hole onto the wall, that the drill to the wall will cause a lot of heat. The heat will not hurt the wall, but the heat will hurt our bone cell. Our bone cell couldn't resist it over 47 Celsius degree. So if we get a lot of heat into the bone, then the bone cell will get necrosis. As we know, the successful factors of the implants first is related to the osteointegrations, means that the bone cell need to be deposited and survive onto the implant surface. So if a bone cell is already dead, that osteointegration will not be successfully achieved. So that's why we say longer implant is favorable, but has limitations. The other limitations were coming from the anatomy. For example, on the lower, we have inferior alveolar nerve. On the upper, we have a maxillar sinus. So the alveolar ridge to those 2 different anatomies landmark will cause us has the limitation to place the implants. So not just only need to determine the length of the implants, also the diameter of the implants is also important because we have to look at the indenture's area space to determine how the proper crown size, and as crown size were related to the implant size, because if you don't place the implant properly, then the emergence profile or aesthetic of the crown will have an issue. Also, they will cause us has a difficulty to clean it As you can see, this picture shows you that some tooth actually is wider, just like our upper central incisor or the upper posterior teeth. So those areas may need a little bit wider implant than the other area. However, we do know the most smallest tooth will happen in the lower anterior teeth, especially in the central and lateral incisor of the mandible. So in those specific area, actually we have a very limited space to place the implant, and also will cause the difficulty to place the implant. So what the emergence profile means? The emergence profile means that the contour of the tooth or restorations, such as a crown on the natural tooth or dental implant abutment, as it related to adjacent tissue. So the tooth and crown contour as they transfers from the soft tissue toward to the contact area interproximally, and height of contour facial and lingually. So as we can see, the emergence profile actually is talk about the curvature from the root to the crown. So in the implant restorations that were related to the implant body width to the crown width. As you can see in this case, the implant was be placed in the wrong position, so which is caused that on the distal side of the crown actually is much wider than the mesial side. So on the emergent profile, actually the right side or the distal side actually is way more than the desired emergent profile. So what's the problem will be caused by this is you can see they will have a lot of dark space, or what we call the undercut area underneath on the distal crown space. So we were able to determine or assume that will have a lot of like food debris or the plaque will accumulate around the area, which will cause the periimplantitis or even the implant failure. So how to select the right implant diameters, also related to the implant crown, is a very important factors. Meanwhile, in this case, that we can see the implant was placed too mesial compared to the crown. So the other important factors related to the treatment planning will be how to locate it of the implants. Nowadays, we are use the prosthetic-driven implant planning concept to design the implant restorations. The reason is that we want the implants could be in the center of the restorations. So first, we have to determine how wide and how buccal lingual widths should be of the implant restorations, and then we place the implant ideally into the center of the restorations. When we look on the occlusions, that the implant alignment should be follow and parallel to the occlusal force, because we know the implant doesn't have a PDL, so they are not good at resolve the lateral force. So we don't want the occlusal force is coming from the lateral. The occlusal force is better coming from the central. The other factors will be the remaining bone structures. So after we place an implant, the research shows that at least we want 1 millimeter bone surrounding by the implant. If the remaining bone is less than 1 millimeter, the research still shows that they will have a higher chance the bone will remodeling and finally fully resorpted. So it will cause the dehiscency of the bone to implants. The 1 millimeter remaining bone around the implant is the minimum. However, we also need to think about aesthetic. The research still shows that if we don't have enough bone volume, then we will not be able to support the soft tissue. Means that the dental papilla will resorpted. In this famous research done by Dr. Tano and his colleague in 2000s, they found out that the ideal implant to implant distance will be around 3 millimeters or over. The implant to natural tooth will be 1.5 or more. The implant buccal bone width will be ideally over 1.8 millimeters. So, if the implant to implant or implant to natural tooth distance is less than this recommended, that the research shows that the bone between the implant or the natural tooth will be remodeling. After remodeling, the bone will be less than the ideal, so you couldn't support enough soft tissue. Finally, that the dental papilla will lost and cause what we call the dark space, which will cause an anesthetic result. Also, the implant buccal bone width need to be over 1.8 millimeters, so will be enough to support the buccal plate. If the implant doesn't have the buccal plate to support it, then there will have some deficiency in the long-term result. This slide is to talk about when we design the implant single restorations, we have two options. One is about cement-retain, one is about screw-retain. If we look on the retrievabilities, that the cement-retain will not easy, but the screw-retain will be much more easier. That's why in the first beginning, the most restoration will be done by the screw-retain restoration design. However, more and more people choose the cement-retain because the aesthetic factors is important for the implant restorations. And we do know that the cement-retain restorations will be easy to get aesthetic because there will no screw hole will be seen. However, the screw-retain restorations, if the implant was not placed properly, then the screw hole may happen in the facial of the crown, which will cause an anesthetic result. When the implant was not be placed in the ideal position, the cement-retain restoration also will be easy to correct that misalignment. However, the screw-retain will have some limitations. When we deliver the crown, the cement-retain crown will be more familiar to the clinician because those procedure is almost the same as what we deliver a crown on the natural tooth. However, the screw-retain will have a little bit slightly difficult. The space requirement of the cement-retain will be more than the screw-retain. Compared to the force distribution, the cement-retain will be more easier to get the peri-implantitis because the force will be so easy to accumulate around the neck to the implant's body. However, the screw-retain, the more force will be around the connection area, which will cause the screw fractures. So as you can see, different design has the different benefit, but also will bring the different complications. In the previous slide, I said the cement-retain single restorations will need more space than the screw-retain restorations. So let's look into the detail how much space there will be needed. So this is a picture showing you two different designs. On the left side is a cement-retain. As you can see, the abutment is screwed into the implant, and on top of it, the crown will be cemented onto the abutment. On the right side, the picture shows is the screw-retain. Means that the total abutment with the crown will be universal unit and be screwed into the implant bodies. As we know, if we want to make a crown, if we use all ceramic or the PFM crown material, that usually need to have 2 mm occlusal clearance for the crown strength. For the abutment height, to get enough strength and retentions, the abutment height need to be over 4 to 5 mm. So it comes up, the numbers is that the space requirement for the interocclusal space related to from occlusal surface to the gingival line, that the minimum is 5 mm if you want to do a screw retain restorations. However, the cement retain restorations will need to have more than 7 mm. So, as we can see, if the interocclusal space is less than 7 mm, then the ideal implant crown design will be screw retain. However, if the interocclusal space is less than 5 mm, then the implant restoration is not a good option in that area. Also, we need to think about the mesodistal width. Remember in the earlier slide, we talked about when we place the implants, and ideally we want to have 1 mm bone around the implants. And also we talk about the implant diameter is important related to the implant crown emergence profile. So we usually place 3.5 to 4.5 mm implants into the socket because that will be able for us to do the most of the implant crowns. So if we put the 4.5 mm as our reference point and to get another 1 mm bone surrounded, so basically we are talking about 6 to 7 mm of the mesodistal width. It means that if the mesodistal width is less than this, then you may need to select a smaller implant, or sometimes even you are not able to find a proper implant width to place the implant into the location. So to know or to estimate the proper interocclusal space and the mesodistal width is very important when you do a treatment planning. In the followings that we will started to talk about, those factors will affect the surgery and the prosthesis. So it may include the surgery, the impressions, the prosthesis, and the follow-up. So first, let's look at the implant restoration impressions. First, I want to introduce you is what we call the open tray technique. Now this is a video we're showing you how to do an open tray technique.
Open tray technique using the direct pickup coping. Read the laser markings on the top of the healing abutment to verify the platform size, emergence, and collar height of the abutment. Remove the healing abutment and confirm that the prosthetic platform is free of any bone or soft tissue debris. Select the direct pickup coping that matches the emergence and platform size of the healing abutment. Place the direct pickup coping on the implant body and retain by hand tightening the direct pickup coping screw. Try in the custom impression tray or modified stock tray to verify that the coping screw protrudes through the tray without interference. Syringe medium or heavy body material around the coping body, leaving the screw exposed. Load the impression tray with material and make the impression. Once the impression material has set, remove the coping screw by hand and remove the impression tray. Verify that the impression material is completely adapted around the direct pickup coping. Replace the healing abutment immediately to prevent the soft tissue from collapsing over the implant. Attach the appropriate diameter implant analog to the direct pickup coping in the impression and insert the long coping screw through the access hole in the impression tray. Hand tighten the coping screw. Verify that the coping and analog are properly assembled. Syringe soft tissue replica material around the analog. Fabricate a working model using minimal expansion, high hardness die stone. Articulate the model according to normal laboratory procedures.
So as you can see, this is the open tray technique. And in the following, I will show you the closed tray technique. After those two videos, then we will discuss what's the major difference between those two techniques.
Closed tray technique using the indirect scoop coping. Read the laser marking on the top of the healing abutment to verify the platform size, emergence, and collar height of the abutment. Remove the healing abutment and confirm that the prosthetic platform is free of any bone or soft tissue debris. Select the indirect scoop coping that matches the emergence and platform size of the healing abutment. Place the indirect scoop coping on the implant body and secure using the included screw. Block out the hex hole on the top of the indirect scoop coping screw. Syringe medium or heavy body material around and over the indirect scoop coping. Load the impression tray with material and make the impression. Once the impression material has set, remove the impression tray. Remove the indirect scoop coping and replace the healing abutment immediately to prevent the soft tissue from collapsing over the implant. Attach the appropriate diameter implant analog to the indirect scoop coping using the coping screw. Index the coping into the impression by inserting the coping assembly into the corresponding location in the impression. Send the impression to the lab. Verify that the coping and analog are assembled and seated properly. Syringe soft tissue replica material around the analog. Fabricate a working model using minimal expansion, high hardness die stone. Articulate the model according to normal laboratory procedures.
So before we discuss further into the implant impression technique, I want to reinforce some terminologies that you may just first heard it into the video. So this is the implant with abutment, which will have a screw inside to tighten it. And the tool that we can remove or tighten the screw is what we call the hex driver or the screwdriver. It was just like what you did for the nail to the wall. You also need those drivers to put the screw in to the wall. So we use the hex driver to put the screw into the abutment and the implants. The second terminology is impression coping, or sometimes is called impression abutment. So those will be the items need to be put over the implant bodies and take impressions. Because the implant is not directly be exposed, so we will not be able to take impression directly into the implant. That's why we have to have those impression coping or impression abutment to give us related locations. So it comes up to the third terminology, which is called implant analog. Because in our impression, we actually is to take the impression of the impression coping, not the implant. So when we pull out the cast, we do need to have items into the cast to resemble as the implant. That's why we call implant analog. After you're familiar with those three different terminology, let's take a look about the difference between the closed or open tray technique. As you can see on the left side, if you review the video, you will find out the impression copings on the open tray technique. The screw actually is exposed outer to the tray. That's why we call open tray, because you have to make a tray and really open the hole so you can reach to that screw hole. So meanwhile, after you finish the impressions, before you really pull out the tray, first is you have to unscrew the impression abutment to the implant so you can take the impression out. On the right side show you is the closed tray. The closed tray technique actually is very similar like what you take the normal tooth impression. So the impression coping actually is all emerges underneath the tray. So after you finish the impressions, you can directly pull the impression out. The only difference is that, as you can see on the left side, because you just remove the screw on the open tray technique, so impression coping actually is always fixed into the impression material. However, on the right side, the closed tray technique, actually the impression coping will be separated from your impression. So eventually you have to put impression coping with the analog and reposit those back to your impressions. So you can see the difference between the open tray and closed tray technique actually affect the accuracy of the impression. So this 2014 systemic review shows us the result to say the open tray technique actually is more accurate than the closed tray technique if we want to treat the complete edentulous patient. Means that if you need to do an impression for a multiple implant at the same time, open tray technique is more accurate. However, if we talk about the open tray technique or the closed tray technique for partial edentulous patients, means that you are just only took a single implant restoration. That's no significant difference. So it means that if you want to do a single implant restoration impression, you can either to use open tray or the closed tray technique. However, in the University of Detroit Mercy, that we were more like you to practice the open tray, as you can see, because open tray is more widely can be used in the different scenario. If you want to take a multiple implants at the same time, the research also said you may want to sprint the impression coping together, because the sprinting impression technique is more accurate for the both partial or complete edentulous patients. However, the implant angulation also affects the accuracy of the implant impression. That's why if the surgeon doesn't place the implants into an ideal position, it may also cause some deficiency. However, even we know the open tray technique used to be the same or better than the closed tray technique, but in some scenario, we may still need to use the closed tray technique. For example, if a patient with a limited endodontic distance or insufficient space to use those screw retain impression coping for the open tray technique, that would be the time you have to do a closed tray technique. For example, if patient have a limited mouth opening, or the implant location is more in the posterior area, sometimes you may need to use the closed tray technique. However, you have to check the parallelism between the implants if you want to use the closed tray technique, because the angulations between each different implants will affect the accuracies of the closed tray technique. As you heard in the videos, they said you have to select the proper size of the impression coping and analog followed by the implant size. So let me introduce you the naming system be used in the Nehmer implant systems. Because in the University of Detroit Mercy undergraduate clinic, the Nehmer implant will be the only brand you will be used. The concept between the different brands will be very similar, but will still have slightly difference. However, I just want you to be familiar with the Nehmer first, because this will be widely used in your clinic. So, when we look on the Nehmer systems, remember in the previous lectures I told about the naming system on the healing abutment. As you can see on the lower left pictures that it has 3 different numbers. On the left side, that's a number related to the implant platform diameters. On the upper right, that will be the emergent profile diameters. And the last one on the lower right will be the cuff height. So the Nehmer system not just only use those numbers as the reference, they also use a color code. As you may get confused is that when you look on the figure B, you see the implant platform diameter is 3. However, if you refer to the chart which I listed here on the right, you will not be easy to find the 3. You will see 3.5, 4.5, 5.7. So those 3 actually is related to 3.5. Also will be the same situations when you look on the emergence profile. When you look on the emergent profile, as you see on the pictures, it was listed by 4, but actually it was meaning by 4.5 millimeters. So those numbering systems sometimes will make you confused if you are not familiar with that. That's why the color code will help you to get rid of those confusions. When you pick up the impression coping first, you have to know, are you doing the closed tray or the open tray? As you can see, if you want to use the closed tray technique, you will need to get indirect transfer coping. If you want to use the open tray technique, you have to get the direct transfer coping. So you couldn't mix up those 2 different systems related to your impression technique. After that, you will choose a proper size of the impression coping related to your implant systems. For example, if the implant is 3.5 millimeters of the platform connections, then you have to select the 3.5 implant platform of your impression coping. They also will able to use the color code as your reference. Remember I said you take an impression not directly onto the implant because implant is into the bone. So you take the impression is on impression coping. That's why you still need to order an implant analog for the cast pull-up. When you select the implant analog, you also need to check the diameters and the color code to fit with the implant placed in the patient's mouth. After you have all the impression coping and analog, you finish the impression, and finally you will pull out the cast. When you pull out the cast, you will also request to have the soft tissue model, which will be made by the Kerr soft tissue Moonlarge. This technique will be practiced into a SYNLAB sections. After you have a started cast with a soft tissue model, then you will need to pick up a material of your prosthetic. First is the abutment material. You can use the titanium, you can use the gold, or you can use the zirconia. Remember in the previous lectures I said in the first beginning the zirconia abutment is one piece. However, there will have some complication around the connection. So nowadays we are using the zirconia abutment with the gold connection component. Also, if you check the catalog, you will find out they will have a custom abutment or the stock abutment. The stock abutment means that the preparations and the form is already be prefabricated. So most time, if the implant restorations or the implant was replaced, ideally that you will be able to use a stock abutment. However, sometimes we still need to choose the custom abutment. So the stock abutment is prefabricated. The custom abutment means that each patient have different abutment design. So as you can see, then the price of a stock abutment definitely will be cheaper than the custom abutment because you don't need to customize. However, if you need to do some modification related to the implant locations or implant angulations, the stock abutment may not be able to provide you those flexibilities. So sometimes you still need to use the custom abutment, especially in the upper anterior area, which is considered an aesthetic demanding area. So in the school, we will suggest you when you plan the code for the abutment, you want to choose the custom abutment because it will give a more higher price to the patient just in case if you need to use the custom abutment for the patient restorations. After the lab technician finish all the lab work, then they will deliver the abutment and the crown back to you. That will be the time you will start to do the crown delivery procedure. So here I would like to use the cement retained implant single crown as a reference for you to know what you need to do when you deliver the implant crown. So first, you want to do abutment try-in. When you do the abutment try-in, you want to be sure abutment really tight firmly to the implant. However, you couldn't just use your feeling to feel the abutment is really tight well to the implant. You have to take X-ray to verify the fitness. So the photo shows you that the implant abutment should have no gap on the implant abutment and the implant bodies. If you have any gap, even a small slight line, then that will cause the bacterial accumulations or it will cause the screw loosening or screw fractures. After you verify the fitness between the abutment to the implant bodies, then you will start to torque the abutment to the suggested inserted torque. Those suggested inserted torque will depending on the manufacturer's suggestions. After that, you will seal the screw hole with the PVS or the gutta-percha material. Then the following step will be very similar like you deliver a single crown on the tubes. You will do a crown try-in and adjustment. So you have to check the interproximal contact, you have to check the occlusions until everything is fine. After that, you will cement the crown on top of the implant abutment. When we talk about to torque the abutment to the suggested inserted torque, you have to use a specific tool called implant torque wrench or implant torque driver. So on the left hand side, that's a Zimmer implant torque wrench. As you can see, that's an area that will show you how the torque force will be used. You also can adjust it up to the suggestion. On the left side, you will see an area shows you in and out. So those will also come with the arrow followed by the direction. So if you want to torque the screw into the implant bodies, then you have to have the in face to you. And then follow the arrow, so it's a clockwise, to torque the screw into the implants. On the right hand side, that picture is showing you another normal implant torque wrench be used by the different brands. So as you can see, different brands use the different torque wrench, so you have to be familiar with their design. When we do adjustment of the implant occlusions, they were slightly different from the natural tooth crown. Remember, in the previous lectures, we talked about the difference between the peri-implant and the periodontal tissue. We said the implant doesn't have a PDL around the implant to the bone, so it couldn't result more force compared to the natural tooth. That's why if we place a single implant restoration in the mouth, we want its occlusion is a little bit lighter than the adjacent natural tooth. As you can see on the slide, so when patient in the maximum intercuspitations, you want a light but incompleted hold the chin stock. Means that when patient normally bite down, you still can pull the chin stock out of the occlusions. However, when patient really occluded with the full force, which means that you ask patient to really bite down and bite hard, that the chin stock should be able to hold between the tooth to the single implant restorations. And finally is about the lateral force. As we know, implant doesn't have a PDL, so they are not good to resist to the lateral force. So when you check the occlusions, if you found any lateral excursive contact or horizontal force contact onto the implant crown, you have to reduce as much as you can. Means that they shouldn't have any lateral force contact onto the implant single restorations. So you may ask why you need to know so many factors affect the implant single restoration, from the data collection, from the treatment planning to the surgical or prosthetic fabrication. Because the research shows that if you're not doing all the things right, that the implant restorations will have complications. This 2012 research really collect all the possible complications happens in the implant restorations. As you can see, there might be a biological complications or technical complications, and some of them is about aesthetic. If you sum up all the complications, you will find out almost nearly 30% of the implant restorations will have a complication rate. Means 1/3 of the implant single restoration you've been placed may have some issue. Those issues can be small or can be big, but if you need to deal with those complications, means that it will cost most money and time to help patients to deal with those complications. That's why you have to familiar with those factors to affect the implant single restoration successful rate to prevent these complications happens. The other part that is not included in this lectures will be related to the digital implant dentistry. The one I just introduced you is the traditional analog impressions. Nowadays, that the digital methods can be used from the diagnosis, treatment planning until the final crown fabrication. And this digital implant dentistry concept and the content will be introduced in the different course in your following years.